Ladies and gentlemen, it's a pleasure. I thank you very much for the invitation. What I have to do is to give you an overview over external beam radiation, what have changed from the last 30 years. And I want to choose a little uncommon way. I looked into my library, and what I found was the first textbook of radiation oncology from James D. Cox, which appeared in the edition of 1990, reporting the technique and the treatment results between 1980 and 1990. And this is a basis for what have changed over the last 25 years. And this is coming from the textbook directly. And what the colleagues in these times have seen is that there was a clear point that higher doses give a better local control, and these are, of course, clinical local failures, in-field recurrences, very small number of patients, 560 for all tumors, 133 for stage T2 tumors. And it's important that you should be aware that these doses are not the doses who are prescribed today. These are doses specified for the center of prostate. That means it's about 7% lower. 70 gray in this case is nearby 63 gray of the dose specification of today. And what you can see clearly with small numbers of patients is that doses below 60 gray have a very high rate of local recurrences, doses about 55 gray, nearby 60% in-field recurrences. And when you now made a jump into modern treatment times, this is a study published by Anthony Leitman in the JCO with a 10-year follow-up, a dose escalation study. This is nearby 80 gray and specified as the elder treatment forms 88 gray, compared with 70 gray. And most of the patients were low-risk and intermediate-risk patients. And what is clearly seen after a median follow-up of 9 years is that you have a very high rate of biochemical progression-free survival, 93%, and 25%, 20% better than in case of only 70 gray. And, which is quite important and has been reported by Tolkett and JAMA last year, after 10 years in this trial, they looked for the living patients, and of the 333 patients living, 80% of these answered to a questionnaire with a median follow-up of 10 years, and I want not to go over this, but the conclusion was that the treatment with higher doses was not associated with a decrease of long-term quality of life. And this is a meta-analysis of all three forms of low, intermediate, and high-risk prostate cancer, and it's beautiful to see that the higher doses works in all cases, clear by the best results in low-risk prostate cancer, but the doses about 80 gray works very well in local control compared to former times. And so in the guidelines we said that in this group of patients we need a dose of at least 74 gray and below 80 gray. That's the second point. It's important because some clinicians give higher doses, but there is no evidence to do so. The point is how changed treatment technique and treatment delivery over these 25 years. And when you look into the textbook, it's a little bit uncommon for younger colleagues. These are typical field localizations for treatment of the prostate. No CT was used. You see these are individual blocked fields from the lateral side, and you see that a part of the rectum can be spared over the time of 8 weeks of treatment, only part of the bladder and here inside the prostate should be irradiated, and a lot of normal tissue should be irradiated, which was not necessary, but this was the best way at this time. And the next step was three-dimensional treatment planning, and you can see here a clear dose wash. That's the high dose rate, but you can see that major parts of the rectum and also of the bladder receive the full dose. And this next step was achieved over multi-leaf collimators, and you can see how with these leaves you can spare parts, significant parts also of the bladder and also of the rectum. But the limitations of this form of treatment was very well shown, for example, in the Dutch dose escalation trial, 78 versus 68 gray. These were the elder treatment forms, three-dimensional treatment planning, and you can see that major side effects, rectal bleeding, needing laser surgery, transfusion, that there is a very high rate using 78 Gray, and so that's the border to treat these patients. When you are looking for the treatment of the pelvic lymphatics at the time of 1985, you can see a typical four-field treatment technique, anterior, posterior, and the lateral fields, and you can see that the small bowel here, inside here, that the complete rectum is inside, and also the complete bladder in these older treatment forms. And in this treatment form, you had very high rates of severe side effects. The modern times, this is the R2G consensus, how to define the clinical target volume when you treat the pelvic lymphatics. You can see when you give the dose prescription, you can see that you can spare the bladder, you can include the presacral nodes, and this is a very irregular form of clinical target volume. And today it's possible with IMRT, intensity modulated radiotherapy. On the right side here, you can see that the high dose is there, what you want to have them, and the very low dose, about 50% lower, is for the inside the bladder. However, you have a price to pay for intensity modulated radiotherapy, and there is a much higher integral dose of lower doses in the normal tissue. And the next step then was fast intensity modulated radiotherapy. Needs only about 1.5 minutes to treat the patient, in this case with the pelvic lymphatics. And it's very easy to see that this is the target volume here. This is 40% lower dose, about 3 centimeters away, also for the rectum. And with these treatment techniques, you can spare the normal tissue. And you have to combine it with in-room tools, image-guided radiotherapy, and these are all different ones of IGRT, and it's not so important which form you use, for example, tomotherapy or cone beam CT or fiducial markers. The point is that we have no growing evidence that it would help indeed improve the outcome with IGRT. These are data from the Memorial Sloan Kettering Cancer Center published in the Red Journal upcoming this year with a dose of 86.4 Gray, which is no standard. That's very clear, that's no standard. It's a retrospective study, but 180 patients had daily IGRT, 190 had once a week, and a median follow-up of 2 years. And what you can see is that there is grade 2 or more side effects should be about 50% lower from a very high level after 3 years. 20% grade 2 or more side effects for the GU toxicity, that's very high. But you can spare about 50%, and also of interest, after only 3 years median follow-up, retrospective data, but in the high-risk group, there was a better biochemical progression-free survival when IGRT was used. So, coming to the next point, that's the combination of hormonal treatment with radiotherapy. In the 1980s, 1990, it was completely unknown how to combine these treatments together, how long to use anti-hormonal treatment normal-wise. Patients had orchiectomy, and it's well known that a retrospective series after radical prostatectomy, that the patients we treat typically have a higher risk to have cardiovascular morbidity over the time, during the time when anti-hormonal treatment was used, even in the case of patients with severe cardiovascular morbidity. And this is one of the smaller randomized trial published by D'Amico in JAMA 2008, 70 Gray versus 70 Gray plus 6 months anti-hormonal treatment. And after 8 years median follow-up, you had 10% better overall survival, but which was much more important, if these patients had only low comorbidity rate, this means cardiovascular morbidity, then the advantage doubled compared with these who had comorbidities. And a study published last year in the meantime, intermediate risk patients, 500 in every arm from the RTRG 9408 with a median follow-up of nearby 10 years. It was pretty shown that the addition of a short-term hormonal treatment gave a 5% overall survival advantage after 10 years. So this is also the standard treatment of today for intermediate risk. What is with locally advanced PCA? It was an unknown land in the 1990s, which You can imagine here from the textbook, there was no idea how to combine ideally with anti-hormonal treatment. These are stage T3 tumors with CN0 patients. And also you see that with higher doses, the colleagues from that time, they know very well that they have to higher the dose, but they didn't know how without severe side effects. This is the famous study of Michel Bolla, the first study with 10-year median follow-up published in Lancet Oncology last year. And these 10-year results of 3 years goserelin, 80% C3 tumors compared with radiotherapy alone give an impressive advantage in overall survival without a significant difference in cardiovascular morbidity. The most important question then was, how long should anti-hormonal treatment be? 6 months or 2 or 3 years for locally advanced disease? And this was the major EORTC 22961 with a non-inferiority overall survival design for 36 months additional anti-hormonal treatment compared with 6 months. And after a median follow-up of only 5 years, there was a clear overall survival advantage in favor of the long-term endocrine blockade, and so it is now common practice. At that time, in the 1990s, also in 2000, a lot of urologists said it's quite okay what you will do, and radiotherapy may be useful in some patients. However, anti-hormonal treatment alone should work also. And now we have 2 randomized clinical trials. The first is a Wittmark trial, a Scandinavian phase 3 trial, who was compared patients with locally advanced tumors with only radiotherapy plus hormonal treatment compared with hormonal treatment alone. And after a median follow-up of nearby 10 years, you had a 10% better overall survival for the combination, the additional use of radiotherapy. And this was shown also recently by Patrick Ward in a Canadian phase 3 trial with more than 1,000 patients, not the best dose, also hormonal treatment lifelong versus radiotherapy alone for locally advanced tumors. And again, after a median follow-up of 7 years, you had an 8% better overall survival and also a very small difference in quality assurance. So this was the typical treatment. Now coming to adjuvant radiotherapy, and this is very simple. At that time, we had only 100 patients who were treated before local recurrence, and today we have 3 forms of randomized clinical trials also showing a significantly increase in overall survival in the SWOG trial and also in the biochemical progression-free survival. The point is, do margins really matter? And that is the most interesting study given by Stevenson. And this study showed that positive surgical margin had a clear, significant worse outcome. And the extent of margin showed that patients with focal positive surgical margins had also a significant worse outcome compared with these with R0, compared with extensive disease. And the point is, we need pathological review today. This is from Theo van der Kwast from the European study. And when he reviewed 500 cases, he showed that the most benefit came from the patients who had positive surgical margins. A very low rate of side effects had been shown, and we can see when we compare it with the other point of view, radiotherapy for PSA increase. This is a major study from Stevenson with 1,500 patients. It is well known that patients who started treatment before a PSA achieved 0.5 had nearby 30% better biochemical progression-free survival after 5 years. And what we know very well now is that it is a curative treatment. When the patients following salvage radiotherapy achieved an undetectable PSA again, then you can see that nearby 80% are progression-free after 5 years. And so it's a clear curative treatment. And in a new paper published from our group with 300 patients with salvage radiotherapy, we were able to show that the PSA before start of treatment comes down, now below 0.3. And in the next future, I'm sure that we will find in the guidelines that the PSA before start of treatment will be much lower again. And in the major group of 300 patients, it's clear that it's also a curative treatment. It's the most impressive point. When the patients achieve again the undetectable PSA, then they have a curative chance. Ladies and gentlemen, over the last 30 years, I think it was a major point what now radiotherapy can achieve with high local control rates and also a low rate of severe side effects. And I think it's very good comparable to radical prostatectomy. Thank you very much.
Thank you very much, Professor Wiegel. Is there any question from the audience? What's the place of MRI before and after radiotherapy? Because it seems that MRI can give good information in intermediate risk profile cancer about the tumor burden and even the Gleason score. And it could be a possibility to look at the local control of the radiotherapy.
I think it's important in high-risk patients to incorporate MRI into the treatment planning. And so in the German S3 guidelines, we give a recommendation that we can do so, but it's no standard.
Okay. Thank you. Yes? Sorry, Professor Yuneman? Oh, no.
Okay, I can, quick one. Those patients who have a negative margin and have a PSA relapse, what do you do standard for them? Do you still irradiate them afterwards, or what's your opinion? Is it worth it? They have probably 20% chance of infect.
I think these with negative margins have not only a chance of 20% to achieve the undetected PSA range again. I think it's about 40 to 50%. And in the case of positive margins all over, it's about 60%. So in the guidelines, in the European and also in the German guidelines, we recommended it also for PSA increase or persistent PSA for standard treatment when the patient wants to be irradiated, and then as soon as possible when the PSA increases.
Maybe I missed it, but do you have any data concerning the salvage radiation therapy after radical prostatectomy with PSA relapse? Did anything change within the last 30 years?
Yes, that was the last 5 slides.
This was only on the salvage radiation therapy. But I mean, those who had really extensive surgery, and then you do in addition, you know what I'm talking about, and then you do in addition a salvage versus no salvage radiation therapy. Is there a difference, yes or no?
A comparison between the two groups. There is also a major study by Trock published in JAMA 3 years ago that there is a better prostate carcinoma specific survival in these treated additional with salvage radiotherapy compared with wait and see alone. But it's retrospective, and we are awaiting the publication of one randomized trial conducted by William Shipley from Harvard, and I think it will appear this or next year in one of the major papers.
Okay, I think we'll have to move on now. Thank you very much. Okay.